All right, let's jump straight in. Welcome to this explainer, where we're going to break down the crucial 2025 American Heart Association updates. We are focusing specifically on maximizing patient survival through two absolute pillars of care: high-quality CPR and advanced airway management. Whether you're an in-hospital provider or out there as a pre-hospital first responder, mastering these foundational skills is literally what makes the difference between life and death.
Okay, I want you to listen to this jarring statistic straight from the 2025 CARES Hospital Survival Report. Ready? Only 16.8% of non-traumatic, out-of-hospital cardiac arrest patients survive to discharge. Just think about that for a second. Despite all our amazing medical advancements, less than 1 in 5 of these patients actually makes it home.
That's sobering reality right there. That's exactly why we are analyzing these newly updated evidence-based guidelines today. These protocols haven't just been tweaked, they've been redesigned with one singular driving goal in mind: drastically improving those outcomes by optimizing our direct interventions. And we're going to see a huge focus specifically around chest compressions and ventilation.
So, here's our agenda for today. First, cardiac arrest survival rates. Second, high-quality CPR essentials. Third, updates in airway management. Fourth, clearing foreign body obstructions. Fifth, pediatric and neonatal resuscitation. And finally, number 6, advanced care after ROSC. Let's get to it.
Section 1. Cardiac arrest survival rates.
Now take a look at the steep drop-off we're seeing between out-of-hospital resuscitation, hospital admission, and actual discharge. Out in the field, we are achieving sustained return of spontaneous circulation, or ROSC, in almost 35% of non-traumatic cases, and nearly 42% actually survive to hospital admission. But here's the kicker: we then lose more than half of those admitted patients before they can be discharged. What this tells us is that our early on-scene interventions and our post-arrest care have to be perfectly linked to keep these patients alive long-term.
To combat these dismal numbers, the ASA has introduced a unified chain of survival. This is our single, cohesive roadmap. Previously, we kind of thought of in-hospital and out-of-hospital arrests quite differently, right? But this new approach creates one clear standard. It links early recognition directly through high-quality CPR, rapid defibrillation, and straight into advanced post-cardiac arrest care. Every single link relies entirely on the one before it, ensuring this totally seamless care from the living room floor all the way to the ICU.
Section 2. High-quality CPR essentials.
Now we get to the absolute cornerstone of treatment. Because, let's face it, without high-quality chest compressions, nothing else we do is going to work. You might be wondering about the 30-to-2 ratio. Well, it isn't arbitrary. It is highly recommended for adults before an advanced airway is placed, and for a very specific reason. Recent evidence actually shows that rescuers often fail to deliver adequate ventilation when doing continuous compressions. Sticking to that 30-to-2 ratio specifically allows you to pause, deliver a breath, and crucially, guarantee adequate ventilation by physically observing that chest rise. It's a game changer.
And what about when we compare standard manual CPR to mechanical devices? Well, the 2025 guidelines are extremely definitive here. They stress that the routine use of mechanical CPR devices is simply not recommended. Why? Because numerous trials show absolutely no difference in survival compared to good old-fashioned manual CPR. You should only be deploying mechanical CPR in specific, extreme settings where manual compressions are inherently dangerous for you, the provider, or logistically impossible. And hey, even then, you have got to strictly limit any interruptions while applying the device. We have to keep that blood flowing.
Section 3. Updates in airway management.
Okay, let's talk about adult trauma patients. Naturally, cervical spine protection is always going to be on our minds. However, the guidelines state clearly, if a jaw thrust fails to open the airway, your team must prioritize oxygenation. You need to switch immediately to a head tilt chin lift. Because let's be real, a protected spine means absolutely nothing if the patient cannot be oxygenated. A patent, open airway has to remain your absolute top priority in these critical, high-stress moments.
And when you're managing that airway, you must meticulously avoid a super common pitfall: hyperventilation during respiratory arrest. We all know it is incredibly easy to squeeze that bag valve mask way too hard or way too fast in the absolute chaos of a code. The updated standard is precisely 1 breath every 6 seconds. That's 10 breaths per minute. You should give just enough tidal volume to produce visible chest rise, and no more. Anything beyond that can increase intrathoracic pressure and literally decrease venous return to the heart, which completely destroys the effectiveness of the CPR you're working so hard to provide. Section 4. Clearing foreign body obstructions.
So there is a major shift in how we handle severe choking or foreign body airway obstructions, which we know so often precipitate respiratory and then cardiac arrest. If you've been in healthcare for a while, abdominal thrusts, the Heimlich maneuver, have pretty much always been your go-to starting point. So why the shift to 5 back blows first? Because the data is crystal clear. Observational studies show that starting with back blows results in much better overall clearance rates of the airway, and it causes significantly fewer internal injuries compared to just jumping straight into abdominal thrusts.
Check out this algorithm. It brilliantly illustrates the new repeated cycle for severe obstruction in responsive adults. You verify their choking, activate your emergency response, and then you immediately start alternating sets. 5 back blows, followed directly by 5 abdominal thrusts. You just keep alternating those until the object is expelled or the adult becomes unresponsive. And if they do become unresponsive, boom, you immediately transition to your basic life support algorithm and start right into CPR chest compressions.
Section 5. Pediatric and neonatal resuscitation.
Because pediatric arrest is typically respiratory in nature rather than primary cardiac, getting these airway and CPR nuances right is absolutely critical. And guys, this is a massive update for anyone working with infants. For infant CPR, you must now use either the 2-thumb encircling hands technique or the heel of one hand. If you learned the old 2-finger technique, the 2025 guidelines are explicitly telling us to abandon it. Systematic reviews found that the 2-finger method simply fails to achieve adequate compression depth. If your hands are too small to encircle the infant's chest, just use the heel of one hand to ensure you are pushing hard enough. Now, when it comes to neonatal airway management, the guidelines are offering us a critical new alternative. For newborns at 34 weeks gestation or more, if your initial face mask ventilation is unsuccessful, it is now perfectly reasonable to use a laryngeal mask as an alternative to going straight for immediate endotracheal intubation. Studies actually showed no significant difference in first attempt success, and utilizing this can save precious time in establishing a secure airway for our most vulnerable little patients.
Section 6. Advanced care after ROSC.
All right, so you got a pulse back. Awesome. But getting the pulse back is literally just the beginning of the fight. As this flowchart shows, the immediate focus post-ROSC is a synchronized dance. You are simultaneously managing the advanced airway to ensure proper oxygenation without hyperventilating, you're maintaining targeted hemodynamics with vasopressors or fluids, and you're quickly acquiring early diagnostic imaging, like a 12-lead ECG, to figure out exactly why they arrested in the first place.
Let's get really specific on those targets. The underlying why here is that maintaining a mean arterial pressure of at least 65 millimeters of mercury strictly avoids hypotension. And hypotension is absolutely deadly to a brain that has just suffered an ischemic injury. We have to protect the brain. Meanwhile, leaning into early diagnostic tools like point-of-care ultrasound and head-to-pelvis CT scans helps us quickly identify actionable complications, everything from internal bleeding during resuscitation to the primary root cause of the arrest itself. So the science has evolved, giving us the ultimate blueprint for superior airway management and truly high-quality CPR. But as we know, guidelines only save lives if they actually overwrite our old muscle memory. So as we wrap up this explainer, I leave you with this actionable question. When the next alarm sounds, will your team fall back on outdated habits, or are you ready to implement the 2025 standards that actually bring people home? Thank you so much for joining me today. Now get out there and go train your teams.